Today we're going to be discussing the sad and unnecessary death of Hillary Ellington, a 33-year-old mother of three, who died during elective cosmetic surgery at the hands of her plastic surgeon husband, Dr. Benjamin Brown. We're going to look into what happened, why it happened, how it could have been avoided, and most important, how you can avoid the same thing happening to you if you should decide to have an elective cosmetic surgery in an outpatient facility. I'm going to discuss what happened both as a physician and as a board-certified anesthesiologist to get a better understanding of what was going on in this tragic situation. The surgeries planned for the day were extensive. She was to start with a revision of an abdominal scar and an abdominoplasty. She was going to have liposuction bilaterally of the upper arms, lip augmentation, and an ear pinning procedure. This was all going to be done under local anesthesia. The procedures that they had planned for the day were extensive. They would be extensive in a hospital, but they would clearly be a lot in an outpatient facility, especially without an anesthesiologist at the head of the table. They would have been much better served for something like that that's going to require a lot of time and probably have some blood loss that's not seen, to have an anesthesiologist there to monitor the vitals and to give intravenous therapy. This was all going to be done at Dr. Benjamin Brown's outpatient surgical pavilion. In the operating room was Dr. Brown, two nurses, and the patient, Hillary Ellington. It was noted that between the two nurses, the patient, Hillary Ellington, administered herself a handful of pills, which included Valium, Tramadol, a cephalosporin antibiotic, and Zofran. These medications that she gave herself are not unusual for preoperative analgesia and sedation. The Valium is a benzodiazepine. It relaxes the patient. It takes the edge off. The Versed that she was given was probably liquid Versed or a pop, because we don't have a Versed tablet. That is just like Valium, except it gives a little bit more amnesia. If you ever had surgery and you don't remember going from the holding area where you were with your visitors to the operating room, you probably had some Versed before you went to the operating room. The Tramadol was a non-narcotic analgesic, probably to help lower the lidocaine requirement and maybe give a little bit of analgesia after the surgery. The cephalosporin was to avoid staph infections. I don't really think taking an oral cephalosporin just before the surgery would be that effective. If they were really worried about a staph infection, they probably would have given an intravenous cephalosporin an hour before the procedure. And finally, Zofran. That will reduce the incidence of postoperative nausea and vomiting. But that combination of medications that she gave herself, there was no problem with that. What I have a problem with is a lay person picking the medications they're going to get and self-administering them. The nurses then noted that Hillary Ellington then mixed her own Tumescent anesthesia bags. You do that by taking 1 liter of normal saline and adding 2% lidocaine with epi to it. Normally, we add a 50 milliliter vial of 2% lidocaine with epinephrine, which gives us 1,000 milligrams of lidocaine and just under 100 milligrams of epinephrine per 1 liter bag. It was noted that she put more than 1 vial in each bag. However, documentation is poor, so we don't know exactly what concentration of lidocaine was in each bag. This Tumescent IV fluid is not the IV fluid that you think of when you're lying in a hospital and you have an IV dripping into your arm. Tumescent anesthesia is taking liters of normal saline and adding lidocaine and epinephrine to them. That is then injected into the fatty layer of your abdomen, or in your arm in this case as well, allowed to sit there, and it anesthetizes and numbs up a large area. The first part of the procedure was to do the abdominal scar revision. Dr. Benjamin Brown at the time requested some Versed to be given to the patient. He then administered all of the tumescent fluid between the abdomen, and it's uncertain if he put any in the arms at that time. Once he started the abdominal procedure, one of the nurses noted that the patient's feet were beginning to become very twitchy, and she told Dr. Brown, who ignored it. He missed the twitching of the foot, which was the first sign that there was something wrong. The patients would get very fidgety before a seizure occurs. He either didn't know that or chose to ignore it. When we're in the operating room, if a surgeon wants to do a case on the local, very commonly a hernia or a breast biopsy, we limit them to 6 milligrams per kilogram of lidocaine. So, Mrs. Ellington looked to be about 120 pounds in the photographs, so she would be just under 60 kilograms, which would mean we would limit them to 360 milligrams total. Now, when you're doing tumescent anesthesia, it's a little different. They're able to take 35 to 45 milligrams per kilogram. The reason being is when the surgeon starts to do the liposuction and they go in with the trocar and suck out fat and blood and fluid, they're also going to suck out a lot of that tumescent anesthesia. However, there's a problem. We don't actually know the maximum doses of lidocaine for tumescent anesthesia. This was probably a sign that the lidocaine levels were starting to rise already because, like I said, we don't know exactly how much lidocaine was in each bag. After he finished the abdominal part of the procedure, he started on the upper arms and more lidocaine was given. He also instructed the nurses to open vials of pure lidocaine, undiluted, and put them in sterile basins that he could draw them up with a syringe when it came time to do the facial part of the surgery. When he got to the facial part of the surgery, the patient was twitching more and seemed a bit agitated. Again, Dr. Brown didn't really pay that much mind. As he started the facial procedure, the patient told him her vision had become blurry. He didn't heed any warning, and he injected the undiluted lidocaine into her face. After he did that, she now noted that she wasn't seeing colors properly and everything looked orange. When Dr. Brown started the facial part of the procedure, and the patient told him she was getting vision changes, and he just continued to inject lidocaine, it was quite clear that he had no concept of lidocaine toxicity and the signs of it. When a patient is getting lidocaine toxic, they become fidgety. They get ringing in the ears. They get numbness of the mouth. They get visual changes. They start to develop seizures once they get a high enough concentration that it goes through the blood-brain barrier, causing seizure activity, followed by complete hemodynamic collapse and cardiac arrest. However, this patient was getting close to a catastrophic situation, and she had a full-blown grand mal seizure. At which point, the nurses said, "Shall we call EMS?" Dr. Brown said, "No, we will handle this ourselves." He didn't seem to have any medication to control the seizure. He didn't even have nasal cannula or prong oxygen to just give this patient supplemental oxygen. She then went into a full-blown cardiac arrest. I cannot tell you what they did for this patient once she had a generalized seizure. It didn't seem like they had any medications to control the seizure, but I can tell you that once she went into complete cardiac arrest, that operating room was one of chaos and terror. After 20 minutes of unsuccessful resuscitation, they finally called EMS, and EMS arrived. Hillary was taken to the local hospital, placed on a ventilator, where she remained unresponsive for a week. She was taken off life support and her organs were donated. This was an extremely unfortunate and unnecessary situation. Her husband, Dr. Brown, should have known the signs of lidocaine toxicity, and he should have been aware of the maximal dosage allowable before you became toxic. To have a functioning operating room where you're going to do anesthesia outside of a hospital setting, you have to have that operating room certified either Quad A or Medicare. And that ensures that the facility is able to first be cleaned and steriled, has proper medication, proper resuscitation equipment, proper staffing, proper sterilization in order to perform these surgeries. Unfortunately, I have a feeling this was not Quad A or Medicare certified. The reason why is he couldn't even administer supplemental oxygen. That's an egregious departure in the standards of care. So if you want to avoid this happening to yourself, I would always recommend having an anesthesiologist in that outpatient facility. Blood pressures would have been monitored every 5 minutes. Continuous EKG monitoring to see if there were any arrhythmias. Pulse oximetry to make sure the oxygenation was adequate. Probably end-tidal carbon dioxide, just to get an idea of how much respiration was actually happening. They would have had an IV. They would have been able to give intravenous sedation or even general anesthesia, which would have avoided the need for the tumescent anesthesia completely. And they would have been experts in resuscitation. If you want to have an elective cosmetic surgery in an outpatient facility, by all means do. It's very common these days. Many surgeons like to have their own surgical pavilion. It's ease of scheduling. You're working with the same individuals day in and day out. It's completely understandable. But make sure, if you're going to have any type of significant procedure, that you have an anesthesiologist in the room. And ask the surgeon, is this a Quad A or Medicare certified operating facility? If it's not, don't do it. This whole unfortunate case wound up with a dead 33-year-old mother of 3 who now lost their mom and their stepdad because Dr. Brown has been charged with manslaughter. I hope you learned something in this, and I hope you know now how you can avoid this sad and unfortunate catastrophe for yourself. If you do like my videos, I'd appreciate it if you give me a thumbs up, click the bell, and hit subscribe so I can show you some future videos. Take care.